Good morning and a warm welcome to our listeners here in the United States, around the world, and in Africa. I'm Aloysius Uche Odu, Director of the Africa Growth Initiative at Brookings. On January 30th this year, we launched our flagship report, Foresight Africa 2023, here in Washington, D.C. The report is our annual publication which looks ahead to the year in terms of the key issues and trends to watch out for in Africa. Since then, we've launched the report in Botswana, in Kenya, in Tanzania, and in South Africa. We've also hosted a number of events on thematic areas covered in the report. Today, though, our discussion will focus on the health chapter, public health chapter of the report titled Assuring Health Security for All. At a time when countries are ending various COVID measures, there are still many questions unanswered. What lessons have we learned from Africa's response to the pandemic? What are the opportunities and indeed the challenges facing countries as they formulate policies for resilient health outcomes? How ready are we for the next pandemic? To shed some light on these burning questions, I'm delighted to welcome our esteemed panelists here this morning. We have Professor Michelle Williams, Dean of the Faculty, Harvard T.H. Chan School of Public Health. We have Dr. Chikwe Ihekwezu, Assistant Director General, WHO Hub for Pandemic and Epidemic Intelligence. We have Dr. Olusoji Adeye, President, Resilient Health Systems. And we also have Dr. Belinda Achibong. Belinda is a David Rubenstein Fellow with us at Brookings. I'm particularly delighted that these panelists authored essays in the 2023 and 2022 editions of our report. Now, here's what we're going to do. Viewers may wish to submit questions to our panelists by emailing events@brookings.edu, or you can reach us via Twitter by using #ForesightHealth. Our panelists will start by making 3 minutes opening remarks each on some of the lessons and Africa's response to the pandemic. Thirdly, I'll then pose some questions to individual panelists, and finally, we'll take some audience questions. So again, audience can reach us by emailing Brookings, events@brookings.edu, or Twitter using the #ForesightHealth. Let's get started. Michelle, starting with you. In 2019, the Institute of Health Matrices and Evaluation ranked the United States as #1 in terms of pandemic preparedness. When COVID hit, the US was caught flat-footed. Over 1 million Americans died. Some experts believe that the next pandemic is not a matter of if, but when. So why did things go so badly wrong in the United States, and what measures should be taken to stop the next pandemic?
Thank you. First, let me thank you, Aloysius, for that introduction, and also thank you for inviting me to participate and contribute an essay for the Foresight Africa initiative. You know, you start with a very provocative and important question for us to look at and be humbled by. I would say that a number of things went wrong, but I'm going to put it all under the heading of the undervaluation, the underappreciation of the importance of investing in a public health workforce and a public health infrastructure to support health and wellness prior to the encountering of shocks like a pandemic. I think we all know that the United States spends more money on health care, emphasis on health care, than any other nation in the world. But we consistently rank at the very lowest, at the very bottom, despite the enormous investment in healthcare. We still rank at the bottom of all of the major health metrics. And we know that even before the pandemic, life expectancy in the United States was tipping downward. Now, what accounts for that? What accounts for such miserable health metrics statistics in the face of how much we invest in healthcare? I think what accounts for that has been made very clear as a function of this pandemic, in that we do not have universal health coverage. Despite all of the money spent in 2021, even after a year of living with this pandemic, we had 26 million people who were uninsured. What does that mean? That means that they're not engaged in the primary prevention, primary healthcare infrastructure to support and enable their health and wellness during peacetime or in times when a pandemic shock occurs. The other thing that we should recognize is, of all the money that we spend in the US on health care, only 4.4% of that expenditure in 2021, again, a year after we're in the pandemic, only 4.4% was invested in public health systems and support. So I would say, in a nutshell, without going too deep into the details, that what went wrong is the gross imbalance in investing in public health infrastructure and workforce, and I can talk about that later, but also the gross understanding and under-evaluation of public health systems. For too long, the US has thought about public health as a charity activity and have not talked about public health as a strategic pillar of investment for the sake of global health security, for the sake of economic security, and for the sake of maintaining a civil society, nationally and worldwide. And the pandemic made that very clear, that our undervaluation, our underinvestment in domestic public health and global public health infrastructure and the workforce has left us vulnerable, not only to pandemic shocks, but shocks that we're experiencing right now as a consequence of climate change. And I'll stop there.
Thank you very much. Chikwe, you have 3 minutes.
Thank you. Let me pick up from where Michelle actually stopped, because as much as that might have been accentuated in the US for all sorts of reasons, it was more or less the case in every country around the world, just maybe different dynamics and different circumstances. And let me pick up one particular issue that was a challenge for all of us. In almost every country, you saw our leaders appear on TV every night, beginning and later every week, trying to explain what was going on. And beside them stood someone. In the US, it was often Anthony Fauci. There were other similar people in different countries. And they provided, or tried to provide, the data and evidence base for the decisions those leaders were trying to make and trying to communicate to their countries, to their citizens, firstly on what was going on, and secondly on what we should do about what was going on. Now, what became apparent to everyone, and this problem was east, west, north, south, rich, poor, that we were completely unprepared for the to access, to analyze, to use data to inform that decision making. And there are several reasons for that. Some of them are structural through our systems of government in federal, states, and generally the difference in responsibilities around the collection of data. Some of it was because of our hospital systems, our healthcare systems. Some of it was because data streams were just not compatible and accessible. Very few countries could tell you on a daily basis how many travelers were leaving that country to where and from where they were arriving. So there were lots of missed opportunities historically in collecting, accessing, analyzing the data points we needed for an agile and timely decision-making process. Historically, in public health, we were very often confronted with longer-term challenges. With HIV, we could plan a data collection approach, consult, slowly implement, and maybe have data 2-3 weeks or months down the line. But we were confronted with an emerging pandemic that required speed, agility, and systems that actually exist in many other sectors. But we were just not prepared for that level of detail in the health sector. So we stood there very often embarrassed next to our political leaders because we couldn't provide them what they needed to make the decisions, right? Now, Aloysius, we still can't guarantee that our politicians would have made the right decisions, right? Because of whatever, they're elected to make decisions, and we have to give them that imperative, and every society elects the leaders they deserve. But it is our responsibility to give them the best possible opportunity to make the best possible decisions. And I think we collectively were challenged, and that is one of the key challenges that we're trying to address collectively at the moment.
Quite sobering indeed. Belinda, 3 minutes, please.
Thank you very much, Aloysius, and thank you again for everyone. Apologies for the few minutes joining. So let me set my timer 3 minutes, because I know we said we would try and be pithy with the remarks. So a lot of my research, so I do a lot of work in development and environmental economics, trying to understand the effects of epidemics on human capital development, particularly in African countries, and especially in Nigeria. And some of the things that we've learned from this past pandemic, I'm just going to kind of reiterate some of the previous comments as well, were 3 things. One, the importance of health financing, and I think we will discuss this more, both domestically and thinking about the role of international health financing, particularly for African countries. 2, the importance of domestic governance and response when it comes to emergencies. And thank you to Dr. Chikwe and his team. I think we talked about this a little bit earlier for their very, very excellent response to the Nigerian CDC in Nigeria, for example. And 3, the importance of trust from the population in governance and health governance systems, right? So when it came to things like, the take-up of vaccination, these issues on, why are people not as willing to take COVID vaccination, not just in African countries, but also North America and Europe, these things came to kind of full kind of in full relief in terms of trying to understand how do you again respond to an emergency like an epidemic or a pandemic in an efficient way with vaccination, given historic kind of mistrust in vaccines among many populations. So I'm gonna, since I have a minute and a half left, I'm gonna just highlight one thing, and then maybe we'll discuss the others later on the health financing. So African countries are in this unique position where, if you compare the share of donor or external spending in health spending in African countries, is much higher than in the rest of the world, right? So in Africa, it's about 20% of health spending comes from external sources. The average for the rest of the world is 0.5%. So we're in this position where when we look at, again, domestic spending on health, it's quite low related to the rest of the world. We had this Abuja, the Abuja Declaration of 2001, where all the African countries had said we were going to commit 15% of health spending, government spending to health. That did not happen. That has not happened. We'll see, I had some charts in front of me, but I can't show you, but we can talk about it. But if you look at, since 2011, Aloysius mentioned in a note he sent to us, you've actually seen a decline in the share of health spending from government sources, in African countries. So when you add these 2 facts, the fact that you have this large share of external or health spending from external sources in African countries, and you have much lower government spending on health, you are in this very precarious situation when it comes to not just emergencies, but when it comes to things like primary healthcare, right? Because you can have the epidemics, I've been studying meningitis epidemics for years before the pandemic. You can have these epidemics happen, and as Dr. Chikwe, I'm sure has been in frontline of many of these. When you have already very low investment in primary healthcare, this all serves to worsen existing situations, right? Because you then have a population that is already, maybe less healthy than we would like them to be, if there was an adequate or optimal amount of government spending devoted to health. So I'm going to highlight that here, and then I'll stop here and looking forward to hearing more from these discussions as well.
Thank you. Thank you very, very much. Soji, 3 minutes, please. Thank you.
Thank you very much, Aloysius, for bringing us together, and greetings to my fellow panelists. In the next 3 minutes, I would like to highlight 4 elements of lessons learned and lessons that we're still learning, and opportunities to do better as we go forward. I think the first lesson is that in circumstances such as that of COVID-19, it is very important to have clarity on just what it is that we are optimizing for. Because when you look back at the landscape, many times it really wasn't clear what very senior policymakers and politicians were optimizing for. And as Chikwe said, that executive ineptitude was not limited to the United States. It was especially profound in the United States and the UK, for example, but was not limited to those 2 places. So clarity of purpose is important. A second one, especially for the African continent, or perhaps for the global South as a whole, is that in situations such as a pandemic, the consequences of extreme power imbalances between different parts of the world can be very dire. They can come out in the form of over-reliance on other parts of the world for the purchase of medical technologies, whether they're diagnostics or vaccines or therapeutics. Excuse me. It can also come out in terms of who has voice. I'll give two examples in terms of who has voice. In Act A, the body that was set up to broker an efficient global mechanism to enable the low and middle income countries have access. One of the big problems was that there was very poor representation and little voice in real terms of those from the global South. And when this was noted, the WHO special envoy at the time, who used to be a Swedish prime minister, claimed that, that's just the world we live in. He really didn't understand what this was about. I'm not sharing with you any secret. This is in the public domain. Now, if the decision makers had consisted exclusively of people, of individuals from Nepal, Zambia, and Nicaragua, I'm sure the former prime minister of Sweden will have understood why it would be inappropriate for those 3 people to be making decisions of life and death over the people of Europe. A second example of the consequences is this hubris that we have seen and an aversion to evidence. It is abundantly clear that the COVAX mechanism failed in achieving equitable access to vaccines in due time. But just a few months ago, the CEO of Gavi declared that COVAX was the blueprint for achieving equitable access vaccines for people in developing countries in an emergency. That is a profound insult to the intelligence of people in the global South. On the positive side, we realize the importance of institutions. And I would like to single out the Africa Centers for Disease Control in this, because despite all that went wrong on the continent, goodness, just imagine what will have been the case if there had been no Africa CDC. And in addition to that, were stellar people at the country level running country centers for disease control or country national institutes of health. And Dr. Chikwe here deserves credit for that because he was running the one in Nigeria at the time. So the fourth point, and then I will rest, is that a clear lesson that has come out of all of this when we put it all together is that it is ruinous for Africa to be so dependent entirely on the kindness of strangers. Because in times of great stress, you find that you are on your own or you're at the back of the queue. And this is something that the continent really needs to act upon now and for the future. Thank you, and back to you.
Thank you. Thank you all very, very much. Michelle, let's turn back to you. Now, in Foresight this year, you co-authored a brilliant piece titled Empowering Frontline Workers to Develop and Deliver Healthcare Solutions. You cited two staggering statistics. One, that countries need to educate 6 million more nurses to offset shortages. Second, that the world will need about 13 million nurses by 2030. What is the Harvard T.H. Chan School of Public Health doing to address this? And what should Africa's policymakers do to meet these challenges?
Thank you for that question. And I want to answer that question directly about the frontline healthcare workforce. But I also want to underscore a point about the importance of investing early, not only when there's a pandemic, but investing early in supporting and enabling and partnering with African institutions and African scholars for research and research excellence. So, November 2021, Omicron was quietly spreading. And it wasn't until Dr. Sikeleli Moyo, who is one of the chief leading scientists at the Botswana Harvard AIDS Institute, sequenced and discovered this highly virulent and impactful variant. Now, I just said the Botswana Harvard AIDS Institute, an institute that was formed 40 years before to address the AIDS crisis. But by sustaining and continuing to invest in the research institution and capacity building and true partnership in research and science, an organization on the continent was able to provide in very real time important scientific insights that had meaningful impact on global health on the continent, but across the world. So one of the key points that I didn't make in the specific essay on the workforce for frontline workers, I want to underscore here the importance and the value of making sure that we continue to invest in collaborative, and I mean truly collaborative ways, for supporting R&D and research development on the continent, across the continent, and that it is a strategic and important investment that is the right thing to do, but everybody benefits. Now, my interest in making sure that we don't forget the importance contributions that our frontline workforce contribute in times of crisis and in times when we're not in crisis was born out of how we watched the Ebola 2014-2016 crisis really hit hard a very already strained medical clinical workforce on the front line in West Africa. And as this murmurs of this pandemic kept coming forward, I worried that again, we would have a strained healthcare workforce, frontline workforce, nurses, community health workers, and midwives, again, be put in harm's way and not appropriately supported and enabled to do the work that they do. And so I worked with the Africa CDC, friends from the World Bank, and 3 schools at Harvard, the Kennedy School of Government, the Graduate School of Education, led by my school, the School of Public Health, to create a program that would empower, enable, and support frontline workers, particularly chief nursing officers across the continent, to be at the front of the line, to be engaged in training on public health infrastructure management and development, population health management, financial support, and crisis communications. These are important skills that nursing leaders need to have while they're at the table to lead. I think it's important for us to learn from this pandemic and ones before, epidemic threats before, that nursing leaders, midwives, and community health workers need to be at the table to design and then to help implement and monitor public health interventions that come from the science, the scientific enterprise that I started my response with.
So Soji, turning to you, first of all, congratulations. Congratulations, Soji, on your new book titled Global Health in Practice, Investing Amidst Pandemics, Denial of Evidence, and New Dependency. In that book, you wrote that the Affordable Medicines Facility for Malaria illustrates the good, the bad, and the despicable of global health architecture in practice. Can you explain what you mean by this?
Thank you, Aloysius. The Affordable Medicines Facility for Malaria was a public-private partnership designed to help ensure that people in low and lower middle malaria endemic countries could get affordable access to highly effective antimalarials. The origin was a study done by the United States Institute of Medicine. It was called the Institute of Medicine at that time, part of the National Academies, and it was headed by the late Nobel laureate, Professor Kenneth Arrow. Excuse me. In short, it was a response to the fact that chloroquine was failing at the time, and the new drugs, ACTs, were way too expensive for the average or poor person to buy in the malaria endemic countries. So the idea was subsidize the drugs at the factory gate, get out of the way, and let the countries take care of the procurement through the public and private sectors, because in many of the countries, the private sector was where the people got their antimalarials. What was great about this? We built a coalition, and that coalition succeeded in taking that idea from a research or academic exercise to an implementable program. What was also great about it was that, to their credit, several entities stepped up to finance it. The Global Fund, UNITAID, the government of the United Kingdom, and the Bill and Melinda Gates Foundation, as well as Canada, were the principal financiers of that co-payment or subsidy. Also, what was great about it was that several pharmaceutical companies cooperated with us in that exercise, like Novartis, Sanofi Aventis, and Cipla, for example. Those were not the only ones. And the Global Fund hosted it. So we did a pilot of it, a huge pilot, I must say, in 8 countries in Africa. And it was spectacularly successful. The results were published in the Lancet in the last quarter of 2012. Nothing like it had ever been done in global health. The evaluation cost at least $10 million. It was very intense. Now, what was despicable about it? What was bad about it? Because I've talked about what was good about it. What was bad about it was that it took us so many years to go from the idea to testing it in practice. But that was part of the development process. Now, what was despicable about it? And here, I hope our listeners are paying attention. Here we had an extraordinary opportunity to really save lives on a huge scale. Here we had an opportunity to further empower the country so that their own private sector and supply chains will take charge. But guess what? USAID and the United States PMI fought against the AMFM every step of the way. They undermined it every step of the way. Whatever I'm saying here is in the public domain. Their own independent evaluation said the US PMI was undermining the AMFM. And instead of the Global Fund then expanding it, the USAID and US PMI, through the US delegation to the Global Fund, bullied the Global Fund board into essentially abolishing the AMFM, despite the fact that managers, malaria program managers from Africa, explicitly wanted it to continue. And this is the problem. When you have a situation whereby external financing is so prominent, the countries unwittingly self-subjugate themselves to the whims and caprices of wealthy but unscrupulous entities. Because on that occasion, USAID and USPMI were very unscrupulous. They denied the evidence. So when you have this combination of big money coming from USAID and the USPMI on the one hand, and you combine it with the intellectual dishonesty of USAID and USPMI at that time, it's a very toxic combination, and it was a tremendous disservice to the African continent. And this illustrates the problem of dependency. Now it gets worse. USAID and USPMI opposed the AMFM and killed it because the success of the AMFM will undermine the business model of USAID, which is essentially an agency for international contractors. It is not an agency for international development. So that was the motivation. They damned the consequences, they damned the health effect. And if it meant that they will kill a life-saving enterprise to preserve that hegemony, so be it. And the worst of all is that USAID is now preparing to award a $17 billion supply chain contract, again, through those same contractors, when we have demonstrated more than a decade ago that those contractors are not needed. The country can take care of the supplies themselves through their own private sector. So it's an enormous waste of taxpayers' money that USAID is doing. And frankly, as an American citizen who pays taxes, it makes me sick. Back to you.
Thank you very much. Before we proceed, I'll just check with the panel. Any reactions to what Soji just outlined? Some of the elements coming out of his new book. Chikwe, any thoughts? Any of you?
I'll address some of the issues, but I wouldn't kind of address the specific circumstances of what Soji illustrated. He has much better insights into that space. But I think I'll really seek that we focus on the beginning of what he said. To be able to counteract some of these influences, we have to build domestic capabilities and capacities, not only in those areas that are currently attractive around manufacturing and building, but in intellectual capacity. And if we don't invest in that bit, I think we will never be in a position to make the arguments that Soji is so eloquently making in order to shift the conversation. Because this is an intellectual discussion. Yes, there's money, resource, and politics behind it, but we need people that can counteract these arguments with counterfactual evidence and provide alternative mechanisms to develop our continent. And if we don't do that, then we will continue complaining about the inequities of the present without building the future that we seek and desire so much.
Any other thoughts from Belinda? Any thoughts?
Yeah, I will highlight again the beginning of what Soji was mentioning with the importance of having control over your own financing and how this dependence on external financing in the health sector in African countries really then shapes a lot of our health decision-making in ways that maybe we do not, find optimal for the different countries in Africa. So for example, if you look at, the work that we've done, we were looking at the effects of epidemics on economic development outcomes and human capital development outcomes, like, child health outcomes, etc. And what we found was that you see this, a mass, accumulation of health funding directed to African countries, especially during epidemics, right? During emergencies. So one of the things that we had studied was looking at the World Bank projects and World Bank health aid. The World Bank typically does not invest, for example, in health projects in Africa. It's only about 12% of their projects, if you look at least the data as of 2017 or so. And so if that's the case, it's already a small amount of the projects that are going to health in African countries. And also they're then, really responding to epidemics, to emergencies. They're not directing it towards primary healthcare, right? They're not trying to think about the issues with health infrastructure quality or health, supply of qualified health person or skilled health personnel like doctors, right? We have in Nigeria, I think it's 10 doctors per 100,000 population. And I was talking to Aloysius earlier about the Japa trend, as we call it in Nigeria, where you're seeing this increased exodus of skilled personnel. Our doctors are leaving to go to other countries. So when you consider this kind of state of affairs, then what Dr. Soji mentioned earlier about the importance of really, securing health financing domestically and how that helps us shape our own destinies in terms of the investments in health supply, health infrastructure that are really, really crucial, right, in improving health outcomes for our citizens in African countries. It just kind of brings that into stark relief.
Turning back to you, Chikwe, in your essay for Foresight 2023, titled Building Africa's Capacity for Pandemic and Epidemic Intelligence, you wrote that several African countries are at very different phases in building their data collection, analysis, and epidemic intelligence capabilities. However, these processes are proceeding, you say, in an uncoordinated manner. In your new role at the WHO, what are you guys doing to address this problem? Right, thanks.
Sorry about that. The challenges we articulated in the article I articulated, which I've alluded to earlier around analytical capacity, in a way can be also, the same thing can be described in many other sectors, right? When there's a deficit, where there's a reaction generally, the initial reaction is to do something about that deficit by solving the problem or trying to. If you have 54 countries trying to solve the same problem, you end up with different solutions and maybe ultimately end up with a state of confusion that might even be worse than where you started off from. So generally, our response to developmental challenges in public health and in many other spaces has been to develop capacity. Now, our primary premise at the moment at the World Health Organization around this issue is that we must invest in collaboration as well as capacity development and when I say collaboration, we can't expect it to happen as a byproduct, an incidental byproduct of building, right? You have to think together in order to solve this, and to think together, to build together, you have to be intentional about it. So what we're doing is making sure that as countries, there are many countries at the moment trying to set up new centers for disease control or national public health agencies. Africa CDC is inundated by requests. WHO is supporting several countries around the same lines, but we're all trying to build similar things without actually thinking, talking, liaising, and collaborating. So the most important investment of our time at the moment, in addition to the human resources, technology, and expertise, is to make sure that people are actually working together and investing a lot of time, resource, and energy in bringing people together so that they not only learn from WHO, but learn from each other as we build these new capacities that we need across the continent.
Belinda, you alluded to some facts earlier on, which also captured in the World Bank's World Development Report 2022, World Development Indicators about Africa's health expenditure per capita, which has decreased since 2011. And this decline, whether you look at domestic public, you look at domestic private, you look at external sources of health expenditure, they're all, on the decline. Can you help us explain this trend decline and what policymakers need to do to assure health security for all on our continent?
No, thank you. It's a good question. So, and I will also let, I think, Dr. Chikwe and Dr. Soji jump in on this as well, because I know you have a lot more experience working on the government policy side than I am coming from academia. So I'll tell you what I think from my kind of research on this. So two things. One, from what I've talked about, when I've talked to policymakers, especially, at least I'm Nigerian, so I'll speak from the point of view of Nigeria. When they talk about health spending, they will often talk about this as, well, it's social spending, right? So health spending is often not viewed as something that's a priority in the same way that maybe, you have defense spending or big infrastructure spending is viewed. And so if you look at in Nigeria from 1981 to 2018, for example, there has been a slight uptick, right, in the share of government spending devoted to health. But then, of course, as you mentioned, Aloysius, in Nigeria, many other countries since 2011, then you see this decline. So one, I think, again, when you have fiscal pressure within countries, if you view your health spending as something that is kind of a nice thing to have rather than an essential thing to have, then what gets cut in the budget first? It's health. So that's one. Two, if you are on a very commodity dependent country, like a country like Nigeria, where a lot of our fiscal spending comes from oil revenue, then you are kind of subject to the whims of the commodity cycle. And also a third thing is that to the extent that you view, your health spending as something that is an extra thing that's nice to have rather than essential, then you can use it for, electoral purposes. Let's put it that way. And so this is something that we see from the research, right? These three factors. So one, the fact that health spending is viewed as something external that is nice to have rather than essential. Two, the kind of fiscal pressures that states face as a result, they cut health spending first. It's like health and education and the social spending categories. And three, then, instead of viewing health spending as essential, many countries then see it as something that you can use during, again, periods of electoral cycles where you want to do some political spending. So that said, how can we deal with this? How can we address this? And this is something that we had mentioned. So Dr. Chikwe and I were on a big paper with the Lancet, and we talked about this for Nigeria, right? So one of the things that we had suggested there was to think about having a dedicated fund. And Nigeria has done, well, by law, we have tried to do this as of 2014. That is a dedicated fund for health, right? That says that regardless of the commodity cycle, of commodity prices, of oil prices, regardless of changes in our fiscal situation, there will be some percentage of government spending regularly devoted to health, and it will be fixed. The 15% was something that we were aiming for throughout Africa, but it will be a fixed share of government budget that goes to health. That's one. Two, this is something that has been discussed in the US as well, this importance of universal healthcare, right? So national health insurance schemes. Nigeria has done this. I don't think there's been as much uptake in the general population. Unfortunately, there's a lot of information asymmetry. People don't know how to access this. They don't know if it, what if it exists. So I think there needs to be more push from the kind of government side on like this thing exists. It's good to pay into, especially given that in African countries, people are spending 40% of health spending comes from out-of-pocket expenditure. In Nigeria, it's as high as 77% comes from out-of-pocket. I know, as of 2017. Compared to the rest of the world, that's 18%. So Africa as a whole, much higher. Nigeria, biggest country in Africa, even higher share of kind of out-of-pocket expenditure that people are paying towards health. And you also see the substitution between government spending on health and out-of-pocket spending on health is what we've seen in the research, right? So there is a huge need on the part of the population. And when the government is not stepping in with these kind of national health insurance schemes with a dedicated budget going to health and improving health infrastructure, so that includes from the health personnel, and having access to skilled health personnel, particularly in rural areas, away from the urban areas in the countries. This is something that, we know is very important. There was a very nice paper from Edward Okeke recently that showed like, if you have a doctor in Nigeria, you drop into rural areas, you see this steep declines in mortality, which is fantastic. So we know this. We don't need the research to tell us, but we know that this is important, right? Having skilled health personnel. And so having funding for that, funding for health infrastructure, national health insurance schemes so that people are not paying such a high share of their own household budgets and devoting such a high share to health, when government steps in with again more spending on health, all of these are things that we know will be able to address this one variability. I would say if you go back to the 80s, you see this kind of variability in the share of government spending on health, and also then the decline since 2011 that we've seen as well. Dedicated budget, national health insurance scheme, and just having like a fixed fund that says that we will always have, let's say 15% of government spending going to health.
The number 77% of out-of-pocket spending on health in Nigeria sounds absolutely staggering. I just wondered, Soji, Michelle, Chikwe, these are not numbers we're familiar with in other countries. Any further input from you guys? This is stunning.
If I may, I love Belinda's response because it really highlights a couple of things. One is the way we think about expenditure on health. It's false. It's a false premise when we think about expenditure on health and we're only looking through the healthcare lens. Building roads is an expenditure on health, distal to the health outcomes that we might care about, but important. Schools, maternal education is one of the quickest, easiest ways to bring down infant mortality and increase life expectancy. Okay, that's an expenditure on health. We have to get away from siloized thinking about health. Health is in every single policy governments, national, regional, global, have to think about. Health is in every single one of them. The other thing I would say is when we don't spend on public health and primary health care, we end up having all of those expenditures, including 77%, on healthcare when it's too late, when we're trying to rescue health, as opposed to preserving, protecting, and promoting health. So there has to be a mindset shift in how we think about what is health expenditure, who's responsible for making the policy decisions to support population level health at the national and global scale. And then we have to think about, it's not just the amount of money that you're spending. US spends $4 trillion a year on health, and yet we rank the worst because we haven't had the kind of balanced investments in the upstream places of housing security, food security, chronic disease surveillance and prevention. And all of those things require an all-of-government approach in coming up with a rational, thoughtful budget that protects and preserves health, as opposed to having all that expenditure towards the end when we're trying to rescue health wellness at too late and too high a price.
Any thoughts?
Yes, thank you. Let me build on the contributions by fellow panelists Belinda and Michelle. Thank you very much. If we look at the situation just before, in the 2 decades, just before the COVID pandemic hit, and here I'm referring to data available in the WHO's health expenditures database, excuse me, and their associated reports. You find that there is actually a choice that governments make. At every income level, there are variations in the extent to which governments prioritize expenditure on health. So whether a country is low income, or middle income, for example, as a choice dimension there. And quite often in discussions on global health, we unwittingly assume the governments don't have agency, or we infantilize them. That is not the case. They're making choices. Second, excuse me. If you look at the data from the year 2000 to the year 2019, so 20 years to just before the COVID pandemic hit, find a very interesting pattern there for low and lower middle income countries. So for low income countries, for example, find that the share of external finance increased from 16% in the year 2000 to 29% in the year 2019. So it practically doubled. In those same years, the share of government financing declined from 28% to 21%. Okay? And that chart tells its own story. Now, what is going on? There is a perverse incentive here, and it works like this. In many countries, not everywhere, many countries, you ask government officials, why are you not putting your own money, more of your own money into health? And they'll tell you, look, we're not stupid. We know that if we don't put in our own money, or if we don't put in more of our own money, those Europeans and North Americans who love us more than we love ourselves, we convene replenishment meetings, complete with Bono, Angelina Jolie, certain politicians, and then some academics from the East Coast of the United States, some billionaires jumping up and down, and they raise money and they replenish Gavi and they replenish the Global Fund, and the beat will go on. So if you are a minister and your perspective is short-term, if you're a minister of finance and your perspective is short-term, you then tell your minister of health, look, you've got your sugar mummies and sugar daddies out there. And these other ministries, they don't have the same benefactor. So I'm going to allocate money to them. It's a very rational thing to do with those kind of incentives. And if you're a median politician in a high-income country, it's good press if you announce that you're putting in a few $1 million, and then you can be on the front page of Time magazine with a picture of cute brown babies whom you are saving. Now, I don't have anything against cute brown babies, okay? But the point is, the incentives on both sides are totally perverse, and those are things that need to be addressed. Back to you.
Thank you. Thank you very much. Just for the benefit of our viewers, I'd like to bring them in a minute. Again, viewers who wish to submit questions to our panelists, please do so by emailing events@brookings.edu or via Twitter by using hashtag Foresight Health. Now, Michelle, there is a question here from one of our viewers, Miranda Wilson. She's a program manager at AARP here at home. Miranda asks, given the growing number of older adults in Africa and the disproportionate impact of COVID-19 on older people, what policies and are policymakers pursuing to ensure that older people's needs are met in Africa's healthcare system?
That's a really important question, and it fits so beautifully with the theme of this conversation about lessons learned. And I will say that one of the major lessons learned was just how inadequate our health systems are for serving the population writ large. We saw that COVID brought us all to our knees. We also saw, in the US, we lost 1.1 million to date people to COVID. And, it's not just the pathogen itself that leveled so much carnage on the population. It was the lack of investment and commitment to having strong health systems that preserve, support, and maintain health. So we saw people who were elderly, to the question, but also people who had comorbid conditions that could have been prevented, and if not prevented, better maintained if we had a stronger primary healthcare system that supported the prevention or secondary prevention of managing chronic illnesses like diabetes, asthma, respiratory diseases, and hypertension. So I would say the key policy, if we broaden the aperture of this question, and we think really strategically about the lessons learned and what we can do better, the key thing here is to be sure that we are strategically and consistently investing in a primary healthcare system that is robust and pluripotent in taking care of the elderly, the very young, and also those who have chronic diseases that can either be prevented and or managed properly? So that would be my contribution to that very important question.
Thank you very much, Michelle. There's another question here from the audience online from Dr. Winnie Groves, Kingston University lecturer in people science. Chikwe, I'd like to address this to you. What active measures can African policymakers implement to promote greater collaboration with key stakeholders, such as traditional leaders and traditional healers, etc., to ensure the well-being of our citizens?
Thanks, Aloysius. That's a little bit outside of my comfort zone, but we'll give it a shot. I think, I reflect a little bit actually at the beginning of the pandemic, where we were all struggling, right? And we were inundated by different opportunities for cures and remedies, and whatever you could find was thrown at us. And I think this was the same in different settings, and some actually got a lot of political pressure to be tried, given that we didn't really have any countermeasures through the conventional sources. And it highlighted to me a deficit in a process of evaluating opportunities that come. So you can't just say this doesn't work, or you have to actually offer people the opportunity of a process through which whatever opportunities can be assessed. And whether that's first is the research organizations to validate whatever is being presented. Secondly is your regulatory bodies to decide on what level of validity or what options in measuring efficacy is necessary for different tools. So I think there's a complex set of needs that each country and sometimes collections of countries need to organize to think through how these opportunities can be integrated into a healthcare delivery system. So there are many opportunities at the moment that we are not even able to give an opinion on, because there's no process through which an opinion can be given. And the pandemic kind of highlighted that deficit. Some of it is being addressed at the moment, but I still think we have a lot of work to do across the world, across the continent.
Thank you, Chikwe. Soji, there's a question here that I would like to address to you. It's from Matthew Boyce. Matthew is at the Center for Global Health Science and Security. He's a senior research associate. He asks, how should countries in Africa transition from a reliance on international assistance to health for more domestic financing on our continent? It appears Matthew has been listening to you in earlier remarks. Soji.
Thank you. And good morning or good afternoon to Dr. Matthew, wherever you are. Very briefly, a two-part response. What should the countries stop doing? And then how should they do it? What should they stop doing? They should stop abdicating responsibility. The leaders should stop abdicating responsibility to their responsibility to their own people. Because right now, the locus of accountability, let me modify that. The strategic locus of accountability does not lie in the capital cities of African countries for the most part. It lies in New York and Washington and, oh yes, Seattle, London, Brussels, Tokyo. You can name your favorite capital city in the global north. Second, for citizens to hold their own African leaders accountable. I think that's crucial. So, excuse me, what are two things they should stop doing? One, 2 years ago, or about 2 years ago, WHO endorsed the wide use of the RTSS malaria vaccine. Now, malaria has been ravaging the world for millennia, and of course, still a major problem on the African continent. So one would have expected that responsible African leaders will say this time around, they are going to finance this by themselves. No such thing happened. It was Gavi I said, oh, they were going to put about $156 million or so into that enterprise. Now, pause and think about that for a moment. That is a gross abdication of responsibility on the part of those African leaders who did not step up. And it's also a usurpation of power on the part of Gavi. Second example, maybe again about 2 years ago, some over 30 former African leaders publicly were in angst because of a report that the UK was going to cut its funding for neglected tropical diseases. Now, one should have asked them, who neglected those tropical diseases? After all, they were the former African leaders. These were their people. But instead of owning up to it, it was a lot easier for them to just beg their former colonial master, "We are dying, come and save us." That is the kind of mental slavery that people need to get out of. Permission to speak frankly. Now, how to do it? Well, the world has agreed to this target of UHT by the year 2030. So that's about 7 years for planning. So African countries, take with the exception of those in situations of war, for example, should aim to transition out of external financing for basic health services and technologies by December 2030. No more being in beggar status to finance basic maternal health services, routine childhood vaccines, insecticide-treated bed nets, for example. They should be paying for those by themselves, because a government that cannot do that really has no basis claiming to be a responsible government. Second, they should insist that they're done with the current approach to technical assistance. No more tying of foreign aid to technical assistance coming from the country that is financing it. So just because Sweden or the US is paying for quote unquote TA does not mean that providers of such TA should come from Sweden and the US. Instead, they should insist, you really want to assist us on that front? Set up a drawdown fund. We will draft the TORs for what we need. We will evaluate the bids, and we will publish the findings of our bid evaluation so that we truly are the masters of our own destiny. Unless the providers of aid believe that Africans are simply incapable of knowing what is good for them, which is the implicit assumption of the current model. Then third is that the funds that will have been used for those country-specific services in maternal and child health, basic immunization, insecticide-treated bed nets, which, by the way, was 75% of development assistance for health, as estimated by the OECD just before the pandemic struck. Those funds can be used for regional public goods and global public goods. Use them to support the Africa CDC, use them to support research and development on the continent, use them to support education in STEM on the continent, and use them to support viable takeoff of Africa-based manufacturing, so that the next time a pandemic strikes of the kind that we just saw, Africa will no longer have to beg in the northern capitals for help. Now, this is not going to be easy because it's requiring African leaders and politicians to take responsibility, to stop abdicating responsibility. So you're going to hear a lot of opposition to this, even from the global south. But it's something that needs to be done if we are to get out of the current trajectory. Back to you.
Thank you very much. There's also another question here, and Belinda, I would like to point this to you. This is Dr. Angela Pashayan of American University. She's a professor of international development. And Angela asks, how are health issues being addressed in the informal settlements where populations are dense and homes lack infrastructure for water and sanitation?
It's a very good question. So again, I will speak from the point of view of Nigeria, which I'm more familiar with. So one of the things that, if you look at the distribution, I'll talk about health personnel in Nigeria, that you'll notice is that we have something called the community health extension workers, CHOOS. So these tend to be, people coming from the local communities in the rural areas, especially, who they get some kind of basic training and basic healthcare, but they are not skilled health professionals in the same way that doctors or nurse midwives are. So that's one of the things that, for example, Nigeria has done to have a lot of these, the CHOOS, as the kind of acronym is called, distributed to many rural areas. Now, is this a solution that is efficient and optimal? I do not think so. Right. So the research that we know about, what is the effects of these skilled health personnel says, it's much better to have a doctor or even a nurse midwife, a skilled health personnel person in these rural areas than to have one of these community health extension workers. Of course, if you have nobody, potentially having one of the community health extension workers is better than having nothing. So there is a very much, people are, and again, speaking from the point of view of Nigeria, people are kind of taking their lives into their own hands. I mentioned the very, very high share of out-of-pocket expenditure that people are spending on health in Nigeria. And this is something that if you are in one of these rural areas, if you are, again, not just going back to Michelle's very excellent point, right? This is not just about having access to primary healthcare. This is about, do you have the roads, good roads, and are transportation costs low enough for you to even access a clinic when you need one? These clinics, again, tend to be less available in rural areas, unfortunately, than in more urban areas in places like Nigeria. So all of these things then compound to worsen often the health situations of people that are living in more remote areas in Nigeria, and I think can extrapolate to other African countries as well. And so this is something where we're saying, this is why you need health, government health investment and domestic health financing that is really trying to focus on expanding access to skilled health personnel, especially in these rural areas. So I will say, one of the programs that Nigeria has that has tried to address this is the National Youth Service Corps program, what we call the NYSC. So Nigeria has this, a few other African countries have this. So this is where when you have a post-secondary graduate, they take them and you spend 1 year of service, you're randomly assigned to an area outside of your home region in the country. And what, again, the research has found is that when you have skilled health personnel, you have nurses, you have students trained as doctors, graduates trained as doctors, then assigned to more rural areas through these types of programs. Again, it improves health situations for local population significantly. So this is, we're very, very dire circumstances. I come from Lagos. We all come from Lagos in Nigeria. I live in Lagos, and this is something that, in Lagos you can access health clinics pretty easily. There's a high density of both government and private clinics, but much worse circumstances when you leave the urban areas.
Yeah. But thank you very much for that, Michelle. Let me turn to you because in her response, Belinda alluded, as the questioner mentioned, informal settlements. But here in the United States, the rural folks are not having the same access as those of us in urban areas. What's to be done here in your view?
It's funny because sometimes when you look at the within country disparities in health within the US, it's as big as country to country disparities. And I think first, there's got to be a clarity of understanding of how and why these disparities exist. And I think we have to be really honest, and we have to really commit ourselves to understanding the history that allows for this disparities to exist today. That it is not necessarily that Black people of African ancestry or people of Hispanic ancestry are weaker in any way needing more services in any way than anyone else, the white population or the wealthy population. What we see when we look at these health statistics are that historical disparities in opportunities for gainful employment, for education, for adequate housing, for access to water and sanitation, basic services that everybody should be have access to, undergird the health disparities that we see, particularly in urban rural settings. The other thing that we have to reckon with is that there are, as we speak, a political agenda that is depriving people of access to primary health care. We have people dying in the US of cervical cancer, easily preventable cancer in states in the US, southern parts of the US, because we have governments that are denying the access to primary health care by not expanding our version of universal health coverage, the Affordable Care Act. And so in states, like North Carolina and Georgia and Mississippi, women, Black, poor, Hispanic, rural women are dying of an easily preventable cancer, of cervical cancer and breast cancer. So, health is really at the intersection of the historical indifference to certain populations, as well as the lack of clarity of purpose, as we heard Professor Soji say, in ensuring that the basic elements of health and wellness, health as a human right, be available to all people. And really, the urban-rural divide that we see, also we have to be attentive to the fact that the underinvestment in the basic public health system has persisted in these areas for too long. And when we have a talent shortage, just as we see talent shortage in the global space, talent is exported from these communities into communities that are already replete, although not sufficiently so, with the workforce that is needed. We have to be very intentional. We have to connect the dots. We have to understand the economic motives, the political motives, and the lack of governance, even when the motives are pure, that puts us in a place that drives health inequality.
Thank you. Thank you very much for that. Chikwe, in your viewpoint for us a year ago, titled Investing in National Public Health Institutes for Future Pandemics, Lessons from Nigeria. You indicated this particular viewpoint, by the way, is the most downloaded from that particular edition. So I want to congratulate you for that brilliant piece indeed. So you made the point that there are three, at least, big lessons, right, in Nigerian CDC, where you were a Director General. And I'm just wondering how those lessons have informed what you now do at the WHO.
Thanks, Aloysius. And I think the piece in itself sometimes is also a reflection of the timing and the platform through which it was shared. And to think about reflecting on that piece and the work at NCC and the institution, I think the three things I'd like to reflect on is firstly, institutions matter so much on our continent right now. And we're not doing enough intentionally to build institutions. If you think about the development of many other countries that we look up to, a lot of it has been around the development of key fundamental institutions that have driven everything else around them, the ecosystems around them. And we need to do more of that and intentionally focus on building them to grow. And building institutions basically means one of the biggest components of that is building people that will work in them, to grow through them and grow with them and stay in them for them to grow. And that brings me to my third point, and there's the one I'm most worried about, and the one Belinda kind of alluded to casually, but it's at the heart of what I think is the biggest risk that we face as a country. If you think at the moment about people leaving, there's a general concept that people are leaving, what we call the Japa syndrome. But if you think about the impact on the public sector institutions, because already salaries in the public sector institutions cannot keep people. There's no doctor that can survive on his salary working at NCDC at the moment. And I'm only using that example because the one I know the best and the one I feel most comfortable using. So if you can't survive on a public sector salary as a physician working in your national public health agency, how do you stay? How do you grow? And how do you develop that institution? So the consequence in a way of the relative success that we had in NCDC is that everyone there has become attractive to all the other institutions that Soji referred to. And so we're paying two prices at the moment. One is the initial positioning of already being disadvantaged, but a second consequence of losing the rare talent that we had to the people, to the institutions that are already well positioned. And so this, I think, is if I look forward into the future, is one of the biggest risks that we face, that we're losing the talent that we hope will build the future country that we all desire. So, and if we don't do something about this, because it's happening very slowly and it doesn't have a big bang effect, you don't see the destruction it's causing in your faces. But across the health sector in the country at the moment, there's a crisis of human resource, and within public health, that crisis is even worse because it's a historically disadvantaged profession to be in compared to sometimes the more lucrative clinical profession.
Wow, technology is one word we haven't used much in this conversation here today, and Brenda will help us address that very quickly, because in your Foresight essay 2023, you co-authored a viewpoint titled Using Information and Communication Technology to Improve Mental Health in Africa. And in it, you share findings from an experimental intervention on mental well-being. Could you briefly tell us more about the intervention, your findings, and why Africa's policymakers should pay attention to issues of mental health?
Yes, absolutely. Thank you for the question. So this is something where, across the world, I think mental health is completely understudied and underinvested in. This is true whether you're in Nigeria or in the US. I think it's particularly true if you're in African countries. We don't have a tradition of focusing on mental health. A lot of times people will say, oh, go to your pastor or go to, wherever. It's actually spiritual. And that's, there's no issue that you're dealing with actually. But what we're now realizing, at least in the economics profession, and people who study economics, is that actually mental health is very, very crucial for health generally. It is a part of health generally. And also then for all the things that we know, are important for people to live good lives. So for your ability to work and earn an income, for your ability to go to school and earn an education that allows you to earn an income, a higher income in the future. Mental health is at the center of all of these things. So one of the things that we started talking about it more, especially during the pandemic, we saw, I think it was a WHO report. I don't remember the exact numbers, but there was an increase, I believe, and Chikwe and Soji maybe can maybe correct me on this, or Michelle, people that are following the statistics, in reports of mental disorders during the pandemic, right? When people were in lockdown, when people were in isolation, You were cut off from your family, from your friends. And so one of the things that we noticed a lot of, not a lot, but some governments started doing and some private sector companies started doing was giving people these free data, right? So I think AT&T was like, it will give you some gigabytes of data. The Ghanaian government cuts the communication service tax during the pandemic with the idea that, oh, okay, well, if we're trying to figure out what are the things that can address mental health, probably allowing people to stay in touch with people they care about more easily is a crucial part of allowing them to improve their mental well-being. And so one of the things that we did, interventions that we did in Ghana was to say, okay, if we just give people free mobile phone credits, right, that allows them to call, that allows them, gives them some data that they can go on the internet, they can remain in touch with work and employers and all of that. Does that actually improve their mental well-being? And we found, really large economic effects in terms of reductions in reports of mental distress, improvements in mental well-being from this very, very low cost intervention, right? This costs like $7 per person we're giving for a month. So very, very low costs. Huge impacts, especially among very poor consumers in Ghana. And we said, okay, this is something that is low cost, is cost efficient, can be scaled up in almost every single country, and starts to get us to think more about how we can leverage information and communication technology to improve health and especially mental health outcomes in the future. So we people are now getting used to telehealth, for example. Chico was mentioning this, collaborations across countries. I think this is a key aspect of collaboration and maybe something that can address both of these things that we mentioned before with the JAPA trend. And also, you have a lot of skilled doctors that are leaving and people generally don't want to leave their homes, right? People generally, if they have the salary, they have the way to maintain their households. They want to stay, right? They want to stay at home. And so maybe if you have more of these kind of telehealth systems where maybe a Nigerian doctor can work remotely in, the United States or can contribute to knowledge there, can earn a higher income through that. Maybe international agreements that allow these types of exchanges to happen without having people have to leave their countries. All of this could have really, really, I think, I'm an optimist generally, but I think, really positive potential impacts on improving health and improving health, mental health, well-being for African citizens as well.
Thank you very much for that. As we try and wrap up, Michelle, I was just wondering, because I know the issue of mental health is very close to your mind, whether you had any quick comment to what Belinda just said, because it's a big deal here in the United States.
It is a big deal, but I want to make one important point, and I want to underscore what Belinda said. I too am a strategic optimist when it comes to this space, because I think the experiment that Belinda shared with us is just the tip of the arrow of what we can do if we harness the fruits that can come from being smart about using digital technology. I think we have to find ways to leapfrog the old, 5 decades of working up towards the health force. There is not a single country on this planet that has adequate workforce for dealing with the mental health crisis we're facing. And so the key is going to be to harness the technology that we have access to in making it possible to provide mental health care in all corners of the earth. The other thing that it will help do is allow people to stay connected and to communicate and to begin to destigmatize mental health issues, because we have to get over this issue that mental health is different from physical health. You can't have physical health, you can't have a healthy economy if you don't have a population that's fit for engagement.
Thank you for that. Let me, as we wrap up very, very quickly, one point from each of you. The question is, what is your message to Africa's new generation of global health practitioners and professionals? What's your message to them? Shall we start with you, Soji?
Thank you very much. My summary message is the following. The future of health in Africa is in your hands. Do not accept the world as it is. Do not run on somebody else's script. And while it is not possible to change the past, it is incumbent on you to face the present and take responsibility for shaping the future. Always bearing in mind what Cassius said to Brutus. The fault, my dear Brutus, is not in the stars, but in ourselves that we're underlings. Back to you.
Well said. This is the 400th anniversary of the badge, so it's great to be refreshed by a quote from Shakespeare's Julius Caesar. Thank you for that, Soji. Chikwe, any advice for our public health professionals?
Sorry, I have to brush up on my knowledge of the classics, but I think I have a very simple point. It builds to an extent of what Soji says, is that we are the people we've been waiting for. No one else will do this for us. But to do this, we've got to do the grind. It's not enough to shout about inequity and injustices of the past. We have to build the future. And that building doesn't fall from the sky. You have to do the grind. You have to get educated to a very high level in the areas that you want to become knowledgeable, and your right to sit on the table, not by shouting, but by really investing in the skills, expertise, knowledge. There's never been more access to knowledge in my short lifetime than it is at the moment. So you can become competitive in different spaces that were very restricted 10, 20 years ago. And we have to become competitive by gaining the knowledge to then shape the ideas, shape the discussions, and shape the future. Back to you, Aloy.
Very quickly, Belinda, briefly, and then Michelle before we sign off.
So, I think just to build up on the previous comments, first, I want to say thank you to the African health professionals. I think, we talk a lot about the constraints that people are facing, the obstacles people are facing, but especially when you study where we've come from in terms of, we won't go into colonialism too much, but, from where we started out with nothing in terms of the health infrastructure that was imposed in many African countries. And then the kind of severe challenges that people have been dealing with, from primary healthcare to infectious disease control, etc. I think, I'm not biased because I'm Nigerian, but I think Nigerian health professionals are some of the best in the world. Nigerian doctors are possibly the best in the world, just given the sheer constraints and challenges they face, and given how little infrastructure that they have to address and face those challenges. So I think really being very appreciative of the work that people have done, and also encouraging people to say, okay, we keep talking about this exchange as what is the US bringing to African countries in terms of health knowledge and all of that. But I think that we need to have that opposite discussion in terms of these health professionals are bringing so much knowledge, right? There's all of this wealth of knowledge that Nigerian health professionals, African health professionals have, for example, about epidemics, that then the whole world was asking, you guys have been dealing with not just epidemics, but just infectious disease control, all of these things that they've been dealing with for years. And so there's a lot of very, very valuable knowledge that our public health professionals can share with the rest of the world, and should be sharing and should be collaborating, going back to Chikwe's comments earlier, with the rest of the world as well.
Those are valid points. And Michelle, you sit at the epicenter of all this and training public health professionals around the world. Any last minute message for the new generation of global health professionals in Africa?
Yeah, I want to build on what my fellow esteemed panelists have said. The solutions to some of the biggest global health challenges, climate change, the next pandemic, global inequity, is not necessarily going to come from the global north. It is going to come from the place where there is a high density of incredible talent, an incredible appetite for entrepreneurship, and really are people who are driving the creation of really meaningful public, private, and academic partnerships. So keep pushing for that mindset shift, that the solutions are going to come from the continent, and they will be contributing to universal global health improvement and security. And that's a fact.
on that very, very optimistic note from all of you, I would like to really, from the Africa Growth Initiative at the Brookings Institution, thank you all for making the time to join us today. Michelle Williams of Harvard, Dr. Chikwe Ihekwezo at WHO, Soji Adeyi, and Belinda Achibong. Thank you all and have a wonderful day.
Thank you very much, Aloysius. Thank you, everyone.
Everyone. Thank you.